our last scenario, number 10, where one physician is medically directing 4 CRNAs, and each of those CRNAs are teaching 4 SRNAs in 4 concurrent cases. And a reminder here that concurrent cases are not just limited to Medicare, it's any type of case at all. The student ratio is not exceeded because the CRNA is 1-to-1 with each of these SRNAs. So the physician bills as a QK for medically directing. They are allowed to direct up to 4. And the teaching CRNA is billed as QX because they are 1-to-1 with each of those 4 cases. So the CRNA is paid 50% for each of the 4 separate cases as well. Now we'll move on to the documentation requirements on slide 44. First, let's talk about the teaching requirements, and I do understand that not all of our listeners will be teaching facilities, but it never hurts to know, and you may be asked questions on, as Heather indicated at the beginning, you will have to answer a 10-question test if you are going to be asking for or receiving AAPC CEUs, so still pay attention if you're not in a teaching facility. Again, not going to read this out loud, and that this is a CMS documentation requirement that asks that the teaching anesthesiologists are present, and it has to be documented during all critical or key portions of the service or procedure involved. Now, you can already imagine that induction and emergence are considered key portions as those 7 steps of medical direction outline, but there may be other critical or key portions that are left up to the judgment of the anesthesiologist. If there is an issue or a problem with the case, they are present. They should be documenting their presence during that time period that's considered critical or key. And the teaching anesthesiologist must be immediately available to furnish services during the entire procedure. Immediately available is not as clearly defined either, but they must be able to get back to the patient in a hurry. A hurry doesn't define well either, but it has to be something that the anesthesiologist is not tied up doing that would preclude them from getting back to the patient. One of the most difficult things to define when you're looking for things to share with people is how immediate availability is defined. And the best definition that I've been able to come up with under the CMS different carriers is within the physician's reasonable judgment. I've not found a clock time that says how many minutes or a measurable time that says within how many feet, but general good clinical judgment, I